Hi, everyone. We're just going to wait a few moments for everyone to file in and we'll get started. And thank you so much for attending. Okay, well, thank you so much for joining us for our latest media briefing on important healthcare issues in the news. I'm Dr. Adam Kassam, past president of the Ontario Medical Association, which represents more than 43,000 doctors. And for those of you on the call who are wondering where Dr. Rose Zacharias is, she's actually off on spring break. So she'll be back next for the next media availability, and I'll be pinch hitting for this one. This Friday is the third anniversary of Ontario imposing a state of emergency in response to the COVID-19 virus. And that came just days after the World Health Organization declared COVID to be a global pandemic. And this year also marks the 20th anniversary of the SARS outbreak in Canada. What lessons did we learn from these public health emergencies, or what should we have learned? And how are we going to ensure that we can respond quickly to any future threats? Part of the reason why we're all convening here today, because the risk of other outbreaks and even another pandemic is a real one. Physicians, public health experts, and others around the world are watching for signs of any increases in diseases that begin in animals that are transmitted to humans due to human and domestic animal population growth and climate change, the resurgence of previously controlled diseases such as polio, tuberculosis, and measles, the rapid global spread of emerging infectious diseases such as monkeypox, and bacteria that are resistant to the drugs designed to kill them. Today, our expert panel will speak to the action needed to prevent and prepare for future global public health emergencies. We'll hear about work being done to ensure Canada can quickly respond and effectively respond to potential pandemics. We'll also hear about the lingering effects of COVID-19, including what's become known as long COVID. And according to recent data from Statistics Canada, nearly 15% of Canadians reported having had COVID symptoms lasting at least 3 months. The Public Health Agency of Canada recognizes post-COVID-19 condition as a major public health burden. Pandemic preparedness is one of the major areas of focus in the OMA's prescription for Ontario Doctors' five-point plan for better healthcare, which is our roadmap for realistic and achievable recommendations to fix gaps in our healthcare system. Now, Ontario's doctors believe that planning for the next pandemic starts with a robust public health system that has the proper resources to protect the entire population. We recommended the creation of a provincial pandemic plan that's updated every 5 years, and we're actually very pleased and grateful that the Ontario government passed legislation to make this a reality. We've also recommended strategic and sustained investments for public health units so that they can themselves do pandemic planning and their other important work, of course. We also want to make sure that we have a continued and sustainable supply of personal protective equipment, or PPE, so that the healthcare system and providers have an adequate stockpile in future outbreaks. Obviously, we don't want to have what we had experienced in the past, which was shortages experienced at the beginning of COVID. I know that about that personally and in firsthand experience. And of course, that means that we need to expand PPE production in Canada, establish new supply chains to ensure PPE is distributed equitably, onshoring given the global geopolitical challenges that are in the sector. We also finally need a strategy to manage and mitigate drug shortages in the province. And COVID ultimately created a great demand for certain drugs, including critical care and palliative care drugs. All this to say, I'd like to introduce our panel of experts who will talk more in depth about what we've learned about COVID-19 and what comes next. To introduce, Dr. Alison McGeer is a professor in laboratory medicine and pathobiology at the Dalla Lana School of Public Health at the University of Toronto, and an infectious disease specialist and senior clinician scientist with the Sinai Health System in Toronto. Dr. McGeer led the investigations into SARS in Toronto and was a member of the Ontario COVID-19 Science Advisory Table and Canada's COVID-19 expert panel. Dr. Angela Cheung is a senior physician scientist with Toronto University's University Health Network and a professor in the Department of Medicine and Institute of Health Policy Management and Evaluation at the University of Toronto. She helped establish 18 CanCov COVID follow-up clinics across 5 provinces, and she's also the leader of the new long COVID web research network. Finally, Dr. Scott Gray-Owen, who has a PhD in bacterial pathogenesis, is a professor in the Department of Molecular Genetics at the University of Toronto. He's the co-director of the university's new Canadian Hub for Health Intelligence and Innovation in Infectious Disease, which is focused on enhancing Canada's ability to respond quickly to future pandemics. So, where are we going to start? We're going to start with Dr. McGeer. Dr. McGeer, what lessons did Ontario learn from the SARS outbreak 20 years ago. I remember that fondly, and I'm sure you have way more experience than any of us on the panel here today. How has COVID-19 changed the pandemic responses, and what other threats could cause a future pandemic? Oh, you're on mute, Dr. McGeer.
Apologies. Thank you, Adam, and welcome everybody. So we learned a great many things from the experience of SARS, but our major problem was that that experience was really focused in acute care hospitals. And so much of the work that was done after SARS was improving infection prevention control in acute care hospitals. No question that all of us who work in acute care hospitals benefited from it, both in the 2009 pandemic, which wasn't that severe, and during COVID. But although we made progress, there was still much further to go, and we're in the same position now. I think Canadians, Ontarians can be pleased relative to other countries about how well we did with COVID, but it also has highlighted for us a lot of things that we really need to do better next time. One of which Dr. Cheung is going to talk about, which is anticipating that long COVID complicated infections are going to be a problem, and we need to be ahead of the game dealing with them. But equally importantly, two other things. You talked about public health infrastructure. We do not have adequate public health resourcing across the country, and in particular in Ontario, and building our public health system to be able to adequately respond to pandemics is critical. And I think, to me, the second big thing that we need to be able to work on is understanding how we mitigate inequities. They are not only in pandemics, but they're much starker, much more obvious in pandemic situations. And so thinking about how we prepare for the next pandemic, and I say that definitively, okay? We know there's going to be another pandemic. Definitely there will be an influenza pandemic. Influenza pandemics are like death and taxes. They are an absolute certainty. The only question is when. And as with COVID, there will also be other pandemics. Those are just much less predictable and consequently require a broader response than simply the preparation for flu pandemics. So I'm really looking forward to all of the work that we can get started now to try to make sure that we build into our public health infrastructure, build the relationship between our public health and healthcare for the next pandemic, and work on every level of being ready for the next one so we do better. Thank you.
Yeah, thanks, Dr. McGeer. It's a really important point that we have a distributed approach to public health preparedness, and it's great to have acute care hospitals really have a robust and streamlined approach. But as you know, 85% of care that happens every single day across the province happens outside the four walls of a hospital, happens in communities that are often underserved or marginalized. So how do we ensure that those communities are still well prepared for the future? And I think it's a very very well taken. I'd like to now turn things over to Dr. Cheung, who we were just talking about as far as long COVID, and whose long COVID research network recently received $20 million from the Canadian Institute of Health Research last week. So congratulations, Dr. Cheung, on such important work. What do we know about the effects of long COVID, and what treatment strategies do we have for long COVID patients?
Thank you, Adam. So long COVID and the effects of long COVID is very real. There are lots we don't know, but we do know that it's a physical condition with mental health consequences. And the most common symptoms are fatigue, shortness of breath, palpitations, brain fog, and there are up to 200 symptoms that patients have complained of. What we do know is that it affects more women than men. And it's not only affecting health, it's affecting the society, it's affecting ability to work, and also relationships between family members and friends, because there's a lot of disbelief in terms of whether, long COVID is real. In terms of treatment strategies, we really don't have a cure right now for long COVID. What we have been doing is using strategies to manage the symptoms. So for example, we're using resting and pacing, we're using breathing exercises, we're using symptom management. So for example, if someone is coughing and wheezing, then we use steroid inhalers. So I think in order to really understand how to treat and how to better treat, we need to understand the root causes. And there has been a proposal by WHO with some evidence behind it that there are 6 to 7 different causes of long COVID. So immune dysregulation, inflammation, endothelial dysfunction, which means there's abnormalities in the lining of the blood vessels, persistence of virus or viral particles, microclots, mitochondrial dysfunction, which is an abnormality of the powerhouse in the cell, and also a perturbation to the microbiome. And so there are many different root causes that have been described. And what we have done in Canada is to set up a platform, adaptive platform trial called RECLAIM, Recovering from COVID-19 Lingering Symptoms Adaptive Integrative Medicine Trial. And it just got approved by Health Canada for 2 different therapies, oral therapies, for treating, really addressing immune dysregulation, inflammation, and endothelial dysfunction. And so I think there are lots that we can do in the area of long COVID.
Yeah, thanks, Dr. Cheung. And, as a physiatrist, I see a lot of these folks, whether they're in the rehab centers or even out in the community, as far as both their physical and their, respiratory, and perhaps even as you're describing some of the psychiatric challenges that they're dealing with. And so this is really, as we know, it's a novel disease with novel implications and now novel long-term effects. And so being able to really bring together a group of stakeholders like yourself and do really innovate on the fly as far as treatment and possible supports moving forward is not only exciting, but very necessary. We're going to now move to Dr. Gray-Owen. What did SARS and COVID teach us about pandemic preparedness, and how is Canada bolstering our ability to be able to better respond to future health crises?
Yeah, thanks, Adam. Good question. So concerning the lessons from the SARS pandemic, really 2 points stand out to me. The first is it happened so fast, particularly the first one. It came upon us very quickly. It washed over us pretty quickly, and everyone did everything they could to adapt. People in the hospitals and research institutes and government agencies did everything they could to pivot and do whatever they could to help and understand what was going on and figure out how to respond to it. And this was really a challenge because we didn't have the knowledge about the virus. We didn't have the knowledge fundamentally about the disease, the way the disease grew from the viral infection, and how to deal with it in the community. And so this was a real problem, and it had to be figured out along the way. Also, because it happened so quickly, as a researcher, there was not an ability to collect the samples that we needed to try and understand the virus itself on a molecular level, on a fundamental questions regarding how this virus causes the disease and how the disease progresses. And so this is something that was really learned, I think, during the second SARS pandemic. The universities and hospitals very quickly remedied this by setting up biobanks and to collect specimens so that in the laboratories we could really dig in and understand this virus and understand disease and hopefully how to intervene and create countermeasures against the infection. Second lesson, I think, particularly from the first pandemic to me, was that as it passed, it was surprising how quickly society and governments forgot about it. And so the research funding dried up very quickly, and the interest, kind of the scientific interest and the government and public interest in the SARS-1 pandemic passed very quickly. And this is really a tragedy almost, in that if we would have had more time to understand this virus, if we would have had more time to really understand on a molecular level and in the community level how this virus worked, how it caused disease and how it was transmitted, we would have been much better prepared for the COVID-19 pandemic that came later on. Regarding Canada's efforts to bolster our ability to respond to future health challenges, I think the federal government in particular deserves an enormous amount of credit for understanding that the time to respond and build the capacities to deal with future pandemics is now. And that Canada's biomanufacturing and life sciences strategy led to the establishment of $2.2 billion in funding to ensure increased pandemic preparedness in the future. And one major focus of this funding has been the Canada Biomedical Research Fund, which supports high impact research and training to increase pandemic preparedness. And one of the hubs announced recently was our own hub based in the University of Toronto, but really a partnership across Ontario. It's the Canadian Hub for Health Intelligence and Innovation in Infectious Diseases, which we call acute, and which I co-direct with Dr. Jennifer Gommerman at the University of Toronto. And it's really working to enhance Canada's ability to respond quickly, effectively, and equitably to future pandemics by increasing our biomanufacturing capacity within the province and across the country, strengthening our talent pipeline, and incorporating health intelligence into preparedness measures. And these are comments that Dr. McGeer and Dr. Cheung brought up earlier on. The hub brings together over 80 partners, including 8 Ontario universities, 6 research-intensive hospitals, government and nonprofit agencies, and industry to support a really robust domestic pipeline of developing and implementing life-saving vaccines and therapeutics that will target existing and emerging infectious disease threats. And so to put this in perspective, Ontario really does have the capacity, the biomanufacturing and industrial capacity to contribute to a response. And this is working to align their purposes and hopefully empower their purposes with the talent and the innovative responses to infection as they arrive. Beyond the academic and industrial involvement, the inclusion of health intelligence is a key deliverable, and we heard this from again from Dr. McGeer and Dr. Cheung, really bringing in the knowledge regarding potential threats before they emerge, including monitoring the microbes that might arise from the wildlife and transmit to humans, and to better understand the needs of our geographically and socioeconomically diverse populations in Canada, so we can more effectively roll out interventions and countermeasures as they arrive in the future. Really, it's about helping us prioritize concerns and develop solutions before the problem is upon us. And the University of Toronto, I think, has been happy to support this initiative we've recently received funding to really quite dramatically expand our capacity to work with high containment level pathogens through the funding from Biosciences Research Infrastructure Fund. And so this will allow us to work with emerging threats that are around the world, bring them in and understand these before they become a problem here. And so in essence, HiCube's intent is to take advantage of the incredible talent and powerful capacities that we have already established in Ontario and across Canada. And many of these were established during COVID-19. And so we want to extend these and build upon these and align and integrate our research and training efforts to make sure we have the expertise and infrastructure that can allow us to rapidly respond to threats in the future. And again, I think this is something that really, they're impactful investments by the federal government and should be applauded because they're happening now and not happening as the next challenges are upon us. And we look forward to working with the Ontario government in expanding upon their priorities as well.
Yeah, thanks, Dr. Gray-Owen. I mean, it sort of speaks to the importance of collaboration at all levels of government, across institutions, and especially with the geopolitical challenges that are ahead of us as far as supply chains and being in the field. We experience that on a daily basis, and so onshoring domestic capacity and production, being able to scale that for not only the biomedical biotechnology ecosystems, but also right into the grassroots where most of this care is actually delivered as far as an interface. So really important work that all three of you are doing, and I wanted to thank all three of you, Dr. McGeer, Dr. Cheung, Dr. Gray-Owen, for sharing all of your expertise. Now comes the fun part, which is we're going to be opening up our Q&A session, and I'm going to throw this over to OMA's Emily English, who will be moderating this portion of today's briefing. If you have a question, please put it in the Q&A chat, and I know most of you already know how to do this quite well. If we don't get to your questions due to time, the media team will follow up with you, and you can also email media@oma.org with any additional requests for interviews. So with that, Emily, hand it over to you.
Thank you very much. And we have our first question from the media. This one's for Dr. Allison McGeer. It comes from Len Gillis with Sudbury.com. The question is, what should the medical community or public health agencies do differently to ensure better communication to overcome the problem of misinformation that seemed to arise right at the beginning of the pandemic? The medical community and the media were accused of colluding on vaccine stories and the importance of public health measures. What needs to be done if another medical crisis happens?
That's I think, a complicated and difficult question to which, honestly, we don't have all the answers now. A very large piece of it, though, is about understanding going forward that our public health officials have the trust of citizens. And so the reduction in the mitigation of misinformation is fundamentally a question of trust between the person who is talking to you and the person from whom you're receiving information. And so what we need when we go into crises is an existing trust developed between physicians, other healthcare providers, public health systems, and the general population, and making sure that we don't allow the current spread of misinformation on social media to erode that trust in our public health is a critical component moving forward. You know, there are lots of particular strategies that can be used to combat misinformation. In part, it was, I think it was a surprise to everybody that there was so much misinformation spread so quickly on social media. And so it will take time for us to build the defenses against that and to understand how we can have people know where they're getting their information from, know what information to trust, believe in the system. So it's a long-term question, but you're absolutely right. It's one of the critical questions in pandemic preparedness going forward that we honestly didn't have before COVID. Okay, it has not happened in previous outbreaks and public health crises, and so it's I think added to our list of challenges going forward that we need to be able to get information that people can trust to everybody in the course of a pandemic.
Thank you very much. And we have another question. This one's for Dr. Angela Cheung. Can we expect people who have long COVID to eventually recover, or are there some patients who may suffer from long COVID indefinitely?
So it's still early to tell. We have certainly seen patients recovering, but there are patients who basically this is like year 3 and they still have lingering symptoms. Can we actually totally get rid of long COVID? I think that's really the vision of the long COVID web, the research network that's across Canada. So we hope to work together to find solutions between basic scientists and researchers and clinicians and patient partners as well to address this issue. And I think it's too early to tell to say, is lingering symptoms of long COVID going to last like 30, 40 years? I don't know. I'm not a crystal ball reader, but the hope is that it doesn't linger that long and that we will find effective treatment for it.
Thank you very much for that answer. And we have a question for Dr. Scott Gray-Owen. Could you tell us more? How are potential future public health threats identified, and how can we prepare for those threats?
Yeah, this is a really important question. There's too many pathogens out there for us to worry about everyone or have them as a priority to think about everyone and trying to understand everyone. And so really it's building surveillance networks around the world, across the country and around the world. And that this concept of One Health, where we're looking into the wildlife and into the environment, as well as in human populations, is something that's incredibly important. This is one of the reasons that we're expanding our capacity at the University of Toronto in the high containment facilities to be able to bring in pathogens or potential pathogens to try and understand them and to try and understand which have the highest likelihood to jump from wildlife, for example, into humans. And so I think integrating the surveillance networks and having really robust and honest communication between surveillance around the world is going to be really important for prioritizing which ones to focus on, so that the therapies, the interventions, and just the biology so that we can understand and try and defeat these pathogens can be something that we're working on before they cause us any problem.
Thank you very much. And we have a question from Maria Rosales-Gerpe from the Cambridge Times. This one's for Dr. Alison McGeer. How soon could we expect another pandemic to happen? And could you tell us what we know so far about H5N1 avian flu and the risk it poses?
So the next pandemic is sometime between tomorrow and about 30 years from now. Okay, we've been tracking influenza pandemics for roughly 3 decades. The shortest interval is 8 years. The longest interval is 45 years. There's just no way of knowing where it's going to sit between those two. So we're at year 14, and you just have to watch. And H5N1 is, something that we've been watching since 1997. I think people's anxiety levels go up and down over time as we see what happens. They're increased this year for 2 reasons. The first is that this is the first year that H5N1 has hit birds, including chickens, both commercial and home flocks of chickens across North America. It's very large outbreaks in poultry across North America, and a lot of infections also in wild birds. And that, the more infections we have in wild birds, the more interaction there is between different species with H5N1, presumptively the greater the risk is. So that's one thing that's worrying us. And the second thing that's been worrying this year about H5N1 is that there have been what appear to be clusters of infections in mammalian species, okay? Not humans, okay? But mink and seals. And so that for the first time, this virus has demonstrated its ability not just to be transmissible in birds, but to be transmissible in mammals. That in no way means it's going to be a success in humans. Okay, so on the list of research things that we need to know about is a greater understanding of how influenza jumps species, what the critical elements are that allow it to move from birds to humans or from other mammalian species to humans. And that's information we just don't have yet. So H5N1 might be the next pandemic, but like the 2009 pandemic, the virus could come from a completely different source in a relatively short period of time. We might again end up with a week or two's worth of warning before the next pandemic starts. If we're really unlucky, might start in Canada. It's like Dr. Cheung's crystal ball on the end of long COVID. You want to know that? You really need a crystal ball.
Thank you very much. And we have a question for Dr. Adam Kassam. Are there any practices that we adopted during COVID that should become permanent? Things like hand washing and mask wearing, the importance of vaccines. And are there any practices adopted by the healthcare system that should become permanent?
Yeah, I mean, I think, part of our what's now a lexicon of pandemic preparedness for individuals includes, very good hand washing. We know how to do that now really well. Obviously, masking is, I think, becoming more a part of our permanent daily lives, whether that's sort of, in spikes of respiratory disease around the flu season or into doctors or offices or healthcare settings, we are masking up. And this, of course, follows nations that probably have adopted this masking protocol many years ago. And so I think we're kind of coming up to speed on those issues and sort of the societal and cultural norms that surround our evolution through the pandemic. As far as the healthcare system, I do think that there is now a greater respect for and probably an intention to lean into cross collaborative cooperation between institutions, load sharing between organizations, really distributed knowledge translation to the communities that are being served. And so I think there is this general understanding and hopefully a respect for more partnership, more collaboration, more teamwork, and a breaking down of silos that probably was a hallmark of our prior system and hopefully will be broken down moving forward into the future.
Thank you very much. And we have a question from Megan Ogilvie with the Toronto Star. I'll have all the panelists weigh in on this one, please. Megan says, you're speaking directly to the media today. What's one thing you'd like the media to think about and report on going forward with outbreaks, pandemics, and pandemic preparedness, given that we're still in the COVID-19 pandemic? Perhaps Dr. McGeer, could we start with you?
So the first thing I think is that the media, certainly the Canadian media, has done a wonderful job of communication and translation of information that applies in all of the health crises we've had. Media are, we may think of media as independent bodies, but in pandemics, we're all in this together. And I think what we've seen from the Canadian media has been an extraordinary effort to stay on top of stories and to get the right information out to people. It's been really nice to see. So at the moment, I think, to me, what I'm uncomfortable with in our current situation is that we've all had it with COVID, okay? And that's fine, and it's lovely that people are getting back to things, and it's really nice to see things returning to normal. But there are two sets of people we need to be worried about, and one of them are the people who are suffering from long COVID. There's a really large number of them. We need to be paying attention to that. We need to be making sure that we're delivering the care and support they need. And the second thing is that there are still more people dying of COVID than die of influenza in a regular year. So even though we think it's over, there's still a very large number of hospitalizations and a much larger number than one would like of deaths. And so trying to keep us paying attention to the fact that we may be finished with COVID, but COVID is not finished with us. And making sure that people get the right advice about booster doses. NACI's just recommended booster doses for people over 65 in the spring campaign, making sure when we go into the fall that we're adequately supporting vaccination campaigns, making sure that people know what the risks are and what they can do to protect themselves is still really important. I understand how hard that is. I think most of us maybe aren't interested in reading it, so I'm kind of counting on the media to find interesting ways of being able to tell that story and to keep us focused on going forward and getting back to normal, but still protecting the vulnerable among us.
Thanks very much. And Dr. Cheung, do you have thoughts on what you'd like to see media report on in terms of pandemics?
Well, I also want to echo sort of Dr. McGeer's comments, and especially I think media really plays a big role in knowledge dissemination. Right now it's really easy to have information flying across social media and quickly turn into sort of a bit of a disinformation, misinformation kind of issue. And so helping to convey sort of correct information quickly is a really important thing. The other thing is, as Dr. McGeer was saying, even if the pandemic is dying down, there is the lingering effects. And this is not the first pandemic to have lingering effects. And so sort of right now we're seeing long COVID, but we actually need to pay some attention to all the other sort of post-infectious disease syndromes as well, and what we can do about it. And often the interest is off when, you know, there's been so much media attention on COVID. So COVID is no longer a hot topic, but there are many people who are suffering, and there are many stories of, you know, anything from, you know, can't work to having divorces because of long COVID. So it really has a societal impact in Canada. And I think what I would like to see is media sort of staying on top of the correct information. For example, that vaccination actually decreases the risk of long COVID. The one way of not getting long COVID is not getting COVID, right? So I do see people relaxing around sort of masking indoors and those sorts of things right now. But the reality is, you know, where I work, I still have like 30 cases in my hospital. So it's not gone by any means. And so I think COVID is here to stay. And we do need to be vigilant and to try to prevent not only acute COVID, but also long COVID as well.
Thank you very much for that answer. And Dr. Scott Gray-Owen, do you have thoughts on what you'd like to see media report on in terms of pandemics?
Yeah, I'll echo the comments before. I think the media has done a fantastic job, particularly because things moved and evolved quickly with COVID, and we, you know, had to make decisions and had information that evolved as we learned more. And so the media was fantastic at helping to share that information and try and not scare the public that it's not that we are changing our minds, it's that we're knowing more and more. With regards to looking ahead, I think one of the important lessons that came from this, and something that we have to focus on, is that the research enterprise and even the biomanufacturing enterprise in trying to understand and combat these emerging infectious diseases is something that can't be put together very quickly. You can't go out and hire a whole bunch of molecular virologists very quickly. They're not just sitting around. The infrastructure to do this research in is large and expensive to operate. And so really the ability to respond to these emerging threats early on and really rapidly really comes from having this infrastructure and having this talent available all the time. And so this isn't something that can just sit and people wait for the next emerging pandemic. As Dr. McGeer said, it might be 30 years from now. But really what we're trying to do is work to mobilize this and take advantage of the expertise that we have and apply it broadly to large burden infectious disease threats that already exist around the world. So tuberculosis is something that's been with us forever, and we need to deal with it. And so the individuals who have been working on COVID, working on TB, working on other large infectious disease problems that still cause high problem around the world is the way to keep these people active and trained and have a real strong impact in the time and still be ready for responding to whatever the next threat might be. And so I think this is a real critical point looking ahead, that hopefully all institutions, government and industry and others appreciate that this is really a large infrastructure and talent pipeline that has to be fed and supported so that we can respond as quickly as we did in this last pandemic.
Thank you very much. And Dr. Kassam, do you have any final thoughts on how the media should be covering pandemics?
Yeah, I mean, I think the only thing that I would add probably is that a lot of the conversation in and around the pandemic is focused on our system and the system's preparedness as well. And so what does that mean as far as stakeholders, as far as funders, as far as collaboration between levels of government? Obviously, this is going to be very important. So as we think about healthcare reform, as we think about an innovative path for the future of healthcare in this province and hopefully the country, how does the media play a role in shaping some of that important work? And I think that's going to be part of the task of the media and our colleagues in the media to continue to keep people's feet to the fire as far as different stakeholders at multiple levels of government and organization.
Thank you very much. And we have another question from the Cambridge Times. Dr. Cheung, I'll direct this one towards you because you've spoken a little bit about the mental health impacts of COVID. This reporter, Maria Rosales-Gerpe, is asking, mental health tends to be dismissed. Do we need medical schools in Canada and current doctors to get trained on the mental health aspects of this disease?
That's a very interesting question because on the patient side, often they feel that it's long COVID is attributed to only mental health only. And so, which I don't think is true. I think for sure we need to teach not only medical students, but because it's new, we need to teach practicing clinicians as well. Family physicians, specialists about the neurological impacts of long COVID. One of the more common than anxiety and depression of neurological issues with long COVID is actually brain fog. And so why do people have brain fog and what does brain fog mean? Often people are a bit unclear. It really targets three things: executive function, reaction times, and also short-term memory. And so, like, how can we improve those, and how can we actually teach people to look for those abnormalities in patients who have had COVID is an important issue. And how do we treat? That's the other thing. So we hope to partner with OCFP in Ontario, but other professional organizations as well to teach, and so not only medical schools, but other organizations as well. I would say that mental health is really important. It's part of health. And I'm surprised in this day and age that we're separating, the physical and the mental when we talk about long COVID. When anyone have a debilitating illness, say you're a marathon runner and can't walk a block, you're concerned, especially if you don't know when it's going to end. So I'm not surprised about the mental health consequences of long COVID. And is it actually a direct virus effect? So the virus can affect the limbic system, which controls mood and anxiety and depression. And actually, does it have an effect there rather than like a secondary effect because of how it affects life? It's a bit unclear right now. And hopefully we'll learn a lot through long COVID web.
Thank you very much for that answer. And we have another question for Dr. Scott Gray-Owen. Can you tell us, how is Canada bolstering our ability to make vaccines, and is enough being done in that area?
And this is a really difficult question because the type of vaccine and the capacity to make different types of vaccines really vary depending on what is being targeted and what the pathogen is. And we were very fortunate with the COVID pandemic in that there was good fundamental research done on non-COVID-19 coronaviruses. And so as a research community and as a vaccine development enterprise globally, it was very clear pretty quickly what the vaccines might look like or what they might target and how they should be formulated or put together. We were very fortunate that the technology, the mRNA technologies, were really at a prime point where, even though they hadn't been used before, they could be applied to this virus and develop very quickly. And so as a vaccine, the vaccine pipeline really was informed by the basic science, the research that had been done ahead of time on other coronaviruses and taught us about this one. Having the capacity to make a new vaccine and test it, and it is really a long process in standard times because of the risk that goes along with it. But it's a difficult process too, because until we test it, until it's targeted, we don't really know how effective it will be on a new pathogen to protect an individual, how it will be able to block the infectious cycle. And so this is why it requires a fundamental kind of baseline of basic research that has to occur, understanding the pathogens very quickly. Hopefully, the more that we know about the more different pathogens, the more quickly we can respond. And then having a nimble biomanufacturing community that can produce these vaccines is incredibly important once we know what they should look like and what they should target. And this is something that, you know, it was a very scary early on in the COVID pandemic when, as we talked about, when, you know, our close friends, different countries, the vaccines were started to be developed or other interventions were starting to be developed, and we're fearful about whether they're going to be able to be accessible in Canada. And so building the biomanufacturing capacity that has the flexibility to develop and manufacture different types of vaccines, whether they're protein vaccines or mRNA vaccines or others, is incredibly important. And so linking this is the hub program from the federal government is really about linking this innovation, basic research innovation, to our biomanufacturers in manufacturing in Canada, so that we can respond hopefully whatever pathogen emerges in the future as the greatest threat.
Thank you very much for that answer. And we have another question for Dr. McGeer. Do we expect to see more new strains of COVID? Could there be another strain that's severe enough that we'd have to, again, enforce strict public health measures or even go into another lockdown?
So this is crystal ball time again. The answer is I really hope not. You know, I think the longer we go without a new strain of COVID that it reverts back to an evolution 2 or 3 years ago, the safer it gets, the less likely it is to happen. But it's a little bit like I can't write you a guarantee that the next pandemic of something completely different is not going to start tomorrow, and I can't write you a guarantee that there's not going to be an evolution of coronaviruses. Coronaviruses to virologists are relatively scary, even though they're really small, because they have an innate ability to mutate and change how they infect people and what happens. So I think all of us are still just a little bit anxious that there is room for one more new variant that could cause a lot of trouble if it chose to. But, you know, the fact that we haven't seen it so far, I think is a good and hopeful sign. Doesn't mean that COVID, like flu, isn't going to continue to evolve over time. There's a lot we don't know about exactly what's going to happen, but I think the likelihood that there will be continued evolution of this virus, just hopefully not to the extent of increasing the severity of illness again to a level where we need to worry about additional public health measures.
Thank you very much for that answer. And we have a question. I'm going to direct it to Dr. Adam Kassam. This one comes from Elizabeth Payne, who is a reporter with the Ottawa Citizen. She's asking, do you have concerns that we're following a similar pattern due to the first SARS outbreak when it comes to funding for public health in Ontario? There are broad concerns about cuts coming to public health funding in the province.
I mean, you know, the way I would sort of frame this, you know, the question, but also the answer perhaps, is we just are on the heels of a massive agreement between the federal and provincial governments as far as the Canada Health transfers, and of course bilaterals between provinces and the federal government. And so I think that there is a spirit of collaboration at all levels, who are of course the funders of our health system, broadly speaking, to try and do things a bit differently. I think that we know that there are certain areas of investment. Dr. Grayon talked a little bit about the manufacturing and the biomedical scaling up domestically and provincially. That's going to be a key resource and a key, you know, area of investment. We know that there are areas that include things like streamlining public health responses across jurisdictions so that there is continuity and consistency. These are areas that, of course, require supportive funding from multiple levels. And so what my answer, I guess, globally would be is that I think that there is a spirit of collaboration moving forward at all levels of government that then hopefully have a trickle-down effect with policymakers, with institutions, organizations, and ultimately community partners, where the interface of healthcare and public healthcare happens.
Thank you very much. And I'll turn it over to Dr. McGeer to weigh in on this question.
It's really hard to value an entire system and infrastructure in which the most important outcome is that nothing happens, right? A really good day for our public health system is when there's not an outbreak, or if there is something, it doesn't affect very many people. And because of that, we undervalue it. We spend on our total public health system enough to care for people in hospitals for 3 days every year. We've always known it to be a dramatic underfunding of the system. We put more money into prevention. We would save money in the rest of the healthcare system, but it's really difficult to do. And so, yes, I think all of us who are watching public health are always worried, not this particular situation, but always worried about cuts to the public health system, because it's so easy to cut work in prevention. It's much harder to cut work in where you can see that you need diagnostic tests or you need therapies. That's something where the need is obvious, where you can see it happen. But prevention is, in fact, really critical, much more important in terms of long, healthy life, in fact, than the care that we provide within the healthcare system. And so I think we should all be worried always about cuts to the public health system. And we should all be not just worried about cuts, but actively working to support that infrastructure and to increase the amount of money we're spending on prevention within our health system.
Okay, thank you very much. And I have one more question for Dr. Cheung. There's still a lot unknown about long COVID. What are the most important areas that researchers are focusing on now?
People are focusing on finding solutions, treatment strategies. People are focusing on understanding the differences and who really gets it really bad and who actually just recover from COVID-19. Trying to figure out the various systems, whether it's neurological, cardiovascular, kidneys and reproductive system, really the exact effects on the system and how we can prevent bad outcomes. So there's lots of work going on, even in across the country, and certainly lots of things going on globally as well. And so I am hopeful that we will find some answers in the next few years.
Thank you. And a reminder to the media, we'll have a couple minutes more for questions. If you'd like to ask anything, please put it in the chat now, or you can follow up with us afterwards at media@oma.org. We do have one question that we'd like to pose to all the panelists again. From your perspectives, what is the one lesson that we need to have learned from COVID to either prevent another pandemic or manage one better? Perhaps Dr. McGeer, I'll start with you on that.
I wish there were one lesson, but to me, beyond the need for public health, the people that we traditionally don't care about until there's a crisis, and then suddenly you need everything from them. I think the really important lesson we need to learn is about how the pandemic has made clear so many inequities within society at so many levels. And I'm really hoping that independent of all of the pandemic preparedness, that we can look at what we've learned about or what we've had reinforced about the inequities that we know are happening in society, and spend time focused on trying to make sure that that does not continue.
And Dr. Scott Gray-Owen, in your perspective, what's one lesson that we need to have learned?
Yeah, I think it follows along the lines that we've been talking throughout this hour. Actually, is the investment up front is really what is critical for being able to respond to these challenges. This is true in understanding the inequities in the community. It's true in understanding the biology of the viruses. It's or the bacteria or the fungi that cause disease. And this is both on the public health level, the community level, and on the basic research level, really having systems in place and strategies in place to intervene regardless of what the next challenge might be, because we don't know what the next challenge is. It could be another coronavirus, it could be influenza, it could be, as we talked about, antimicrobial resistant bacteria as a problem. And so building these capacities and investing in the public health, investing in the fundamental basic research to understand molecular mechanisms and immunological mechanisms and the pathogens themselves is really what prepares us and gives us the ability to respond. As I said before, COVID-19, it was an incredible, really an incredible success as far as how quickly vaccines in particular, but also immunotherapies and other clinical interventions arose, considering where we were when it started. And a lot of that relied on research that had been done in other fields, whether it was mRNA vaccines for cancer, fundamental virology studies that were done to understand viruses in general, not even pathogenic viruses, but how viruses work in general, which set us up well for being able to understand what the vaccines should look like and how we might intervene in disease. And so I think it's these investments up front. As Dr. McGeer said, they're not obvious because they're happening behind the scenes. They're happening. They're keeping us safe and they're letting us respond quickly. But they're what's fundamentally important. And so I hope the investments in the infrastructure and the talent and on all these levels will be continued investment that can have impact, not just during pandemic times, but on the other challenges that we have in the healthcare system.
Thank you very much. And Dr. Cheung, I'd like to get your thoughts on a lesson we should be taking away.
So I just want to extend what Dr. McGeer mentioned about the sort of inequities issue to thinking about that Ontario and actually Canada is a very ethnically and racially diverse society and community. And certainly one thing that, if you look at this pandemic, the people who were hospitalized more are more racialized as well. And so these folks are sicker, whether it's South Asians, East Asians, Black, and Indigenous populations. And so when we actually study long COVID, we really need to look at these differences across the various groups. Some groups are more able because they have insurance and can sort of, they can voice their complaints, but others are trying to put bread on the table and will still do sort of, 3 jobs and try to, support their families. And suffering sort of, we need to understand sort of the differences between various populations from a biological standpoint, from a social demographic standpoint, and mental health as well.
Thank you. And thanks to all our panelists. I'm going to throw it back over to Dr. Adam Kassam for any final thoughts and also for closing remarks.
Yeah, thanks, Emily, and just wanted to thank the panelists again. I think one of the things that I would just maybe add on the back end of what you just asked the other panelists is that there are second and third order consequences of any policies that anyone makes, right? And so we have to, I think, be very cognizant and have a broad lens as we apply the lessons that we've learned to future iterations of any challenges that we may face. And so having a broad lens, understanding impact, understanding context, all of these things matter when we're trying to not only introduce policy, but then have policy work in the ways that we intend. And so that would be the only sort of takeaway that I would probably offer on the back end of the question. And other than that, I just wanted to thank everyone for attending today's briefings. I know it's, sort of a quasi anniversary of COVID, which hopefully we don't have to continue to have moving forward. But nevertheless, we're really happy that you were able to hear some of the things that we had to offer as far as expertise. If there's anything that we need to do or to focus on moving forward, is that as the panelists have described, we need a robust public health system with the resources to protect the entire population health. We know that that's a focus moving forward for system reform, institutional work, as well as governmental work. And you can be rest assured that Ontario's doctors are going to continue to advocate for solutions to strengthen our healthcare system. And once again, just a quick plug for our Prescription for Ontario Doctors 5-point plan for better healthcare. So thank you, everyone. Have a happy and safe Wednesday, and enjoy the rest of your week.